Okay, so in the previous lecture, we talked about the pathophysiology of heart failure. And understand that the pathophysiology of heart failure is really kind of the introduction to pharmacology. Excuse me. So now what we're going to do is basically go through all the different drug classes and basically relate them to the pathophysiology compensatory mechanisms that basically identify heart failure. And so the first kind of large class of drugs is the vasodilators, and you can actually further break that down into the renin-angiotensin aldosterone system targets, or the ROS targets, and these are the ACE inhibitors and the ARBs, or the angiotensin receptor blockers or angiotensin receptor antagonists. And then further, vasodilators can be broken down into the hydralazine and isosorbide dinitrate category. So there's 4 different drug classes that are identified as being vasodilators. And so let's at first start with the targets of the RAS system, the ACE inhibitors, and the ARBs. And so we'll go into the ACE inhibitors first. So here's just kind of a review. Here you have angiotensin being converted to angiotensin 1 via renin. Okay, and then angiotensin 1 gets further transformed into angiotensin 2 via the enzyme ACE. Okay, ACE is also responsible for converting bradykinin into its inactive peptides. So remember that, we'll talk about that later. So therefore, ACE inhibitors inhibit this enzyme ACE, and so the outcome here is that there's going to be less angiotensin 2 production. Okay, remember angiotensin 2 is the ligand, and which binds to the receptor AT1. So AT1 is the angiotensin receptor subtype 1. And ARBs, the other drug class, angiotensin receptor blockers, inhibit the receptor. So ACE inhibitors inhibit the ligand, ARBs inhibit the receptor. So there's 2 different drug categories, both inhibiting this renin-angiotensin aldosterone system. Okay, so we'll start with the ACE inhibitors at this point. So ACE inhibitors are all classified by the suffix pril. So anytime you see something pril, understand it's an ACE inhibitor. And so here's all of the clinically useful ACE inhibitors. Essentially, all of them are equally efficacious. None of them really works better or worse than the other. Some of the older ones are a little bit cheaper, so you'll see them more commonly on hospital formularies. Okay, so ideally, we like to use ACE inhibitors for patients that have reduced left ventricular ejection fraction. Okay, but the patient should not really be exhibiting any signs of edema. Okay, because if they are, that really would preclude the use of an ACE inhibitor as a frontline therapy. Okay, however, in the context of heart failure, all right, ACE inhibitors are the frontline therapy. And so if you've got a newly diagnosed patient with heart failure and essentially they're euvolemic, okay, so there's no sign of edema, the ACE inhibitor is kind of your go-to drug for the newly diagnosed patient. All right. So the prototype is captopril. It's the oldest member of the ACE inhibitor category. And mechanistically, these drugs inhibit the enzyme ACE, okay, responsible for converting angiotensin 1 to angiotensin 2. And angiotensin 2 is the one that's biologically active. It's the one that binds to the angiotensin 2 receptor. Angiotensin 2 receptor is also known as the AT1 receptor. I know it's confusing. So angiotensin 2 is the ligand. The receptor is the AT_1 receptor. Okay, and so the rationale here is that these drugs will reverse the compensatory changes that have been activated due to low cardiac output, resulting in low kidney perfusion. Okay, and so clinically, you'll see them outside of heart failure. You'll see them used quite often in hypertension. They're part of the main therapy for the post-MI patients, so right after heart attack. And then, as we said before, they're really kind of your go-to drug for systolic heart failure. And then, if you want to look at the stages or the classifications, patients that have left ventricular systolic dysfunction and are classified as stage A, okay, so the newly diagnosed patient, these are, excellent drugs for those patients. And then as we go further through the curriculum, you'll see that patients that have heart failure and have comorbid renal failure or diabetes ACE inhibitors are a really good molecular target. Okay, and so and understand the reason that we need to inhibit the biological activity of angiotensin II is that basically angiotensin II drives those compensatory responses. Okay, it's going to increase fluid retention of salt and water, and so the patients, if angiotensin II is left unopposed, the patients will become at some point edematous. All right, angiotensin II by itself is a vasoconstrictor. All right, and both of those processes lead to increased arterial pressure, and so inhibiting the biological activity of angiotensin II is really an important therapeutic approach. And so by this mechanistic view, we're actually inhibiting the production of angiotensin II by inhibiting the rate limiting step of the enzyme that's responsible for its production. Okay, and so this kind of reiterates what I just said. So because angiotensin II is a very potent vasoconstrictor, therefore ACE inhibitors clinically produce all of these different changes. So they're going to reduce peripheral vascular resistance. They're going to be able to enhance the performance of the left ventricle. So now we're going to actually alter both preload and afterload. All right, there's going to be minor, very subtle changes to cardiac output and heart rate, so that's good in a systolic heart failure patient. They are vasodilators indirectly because they indirectly inhibit sodium and fluid retention. And because of their mechanism outside of beta-1, there's very little reflexive tachycardia, and so that's really important to note as well. There will be some renal changes. Clinically, we will see some patients demonstrating an increase in potassium, and we'll go through that mechanism in more detail much later in the curriculum. Okay, so ACE inhibitors as a group have relatively little side effects. Patients that are on ACE inhibitors can become hypotensive due to low volume. These drugs are contraindicated in pregnancy, of course. And I said earlier that one of the outcomes or one of the side effects to therapy can be the production of hyperkalemia. So this is excess potassium. Sodium is primarily affected, but the potassium outcome is kind of secondarily. Really the main side effect that most patients complain about is this dry cough, also called the captopril cough. And patients really are kind of annoyed by this. It's not really a dramatically dangerous side effect, but it's one that's probably most annoying. So this is a dry, kind of persistent cough. At first, when patients are first put on this drug, they usually attribute it to being sick or allergies or something, and then after they've had the cough for 5 or 6 months, then they come back to the clinic and they complain about this this dry cough. Of course, patients that have COPD or asthma don't really have a higher incidence of it, but they may complain about it more because they're just typically more sensitive. They have a more sensitive airway. Over time, renal insufficiency can develop, and so for that point, we do start to monitor serum creatinine levels in the patients that are treated with ACE inhibitors. And there are clinical guidelines that suggest when monitoring should begin, but it's usually several months after therapy has been initiated. And of course, if the patient has heart failure and possibly renal insufficiency, you may want to start monitoring serum creatinine anyway. And then the other thing that, and this is a side effect that's typically asked about on boards, is the production of angioedema. So this is a swollen side effect where basically the lips, and it's more pronounced on the lips, but it can also be in the hands as well. But there's basically a swollen accumulation of fluid within the vessels, and typically patients will present with these swollen lips. And this angioedema can occur 4 to 5 weeks after therapy has initiated, or as late as 6 months. Okay, and so typically when patients have angioedema, that's usually a good reason to discontinue the medication and go to another drug class. Okay, and so this is basically a summary chart, which we'll come back to when we review ARBs in a few moments.